Hello, everyone. This is Fluid, Electrolyte, and Acid-Base Balance, Part 2. So we're going to pick it up at Electrolyte Imbalances. So if you're following along in your notes, it's page 5. And so we are going to look at sodium, potassium, and then calcium. Okay, so these are electrolytes, and where that term comes from literally is that when you put electrolytes in water, they dissociate into positive and negative ions, and they can actually complete an electrical signal and make the light bulb turn on. And so that's literally why they're called electrolytes. Anything that has a charge, so it could be inorganic salts. Like I said, we're going to look at sodium, potassium, calcium. It can also be acids and bases, proteins because they have that amino end and they have that carboxylic acid end. They too are considered electrolytes. But we're going to talk about specifically those ions because they have greater control over where water goes with it. And so remember, water is always going to follow salt. And so I'm just going to be talking about those three positively charged ions, but I don't want you to think that the body isn't electrically balanced. So do know that there are also negative anions as well, and chloride is going to be that number one anion. Okay, so once again, we're talking about balance. So the amount that comes in is supposed to equal the amount that goes out. So the same is true for electrolytes in. Like I said, the ones of greatest importance are going to be sodium, potassium, and calcium. So the number one place that we get our electrolytes from, our minerals, is going to primarily obtained through foods. We also get some through water and beverages, and then too, we make some through our metabolic reactions. The premise is that ordinarily, if we obey our hunger and our cravings, that we will obtain sufficient electrolytes. This really is just based on the fact that they do know that sometimes people can get an abnormal craving for substances when they have severe electrolyte deficiency, so pica. I don't know if you've heard of some people have an iron deficiency. They may get the urge or desire to chew on ice. If they have an iron deficiency, some people eat dirt. And so these are just eat rocks, just abnormal cravings and appetites for substances when there's an electrolyte deficiency. I don't know if you've ever had salt cravings. If you're low on sodium, you may get salt cravings. But the general premise or the idea is if there's food available and we obey our cravings, that we will be in balance with our electrolytes. As far as electrolyte output, number one, once again, is going to be through urine output. We also lose some when we sweat, we lose some electrolytes, and then also we can lose our electrolytes through feces. Definitely when someone has gastrointestinal distress, if they've got diarrhea, also when vomiting, then you can get extreme electrolyte loss that can lead to imbalances. So the most important ones we're looking at are going to be sodium, potassium, and calcium. And the reason that we're looking at these is because of the role that they play in that resting membrane potential. All of these are necessary for all muscle function. So smooth muscle, skeletal muscle, cardiac muscle. We need calcium for blood clotting or that won't occur. Also for nerve impulses. So thinking, also control of our processes all are reliant upon sodium, potassium, and calcium. So that's why we're going to look at those in particular. So the first one we're going to look at is sodium. And so remember, sodium is the most important cation in the extracellular fluid. It also is important in regulating our osmotic pressure because wherever the sodium goes, remember our friend water will follow. The regulation of sodium concentration is going to be based on two things, blood volume and blood pressure control, and then also just how salty are we. And so we're going to look at those two things together. All right, so regulation of water and sodium balance. We've talked about this before. We know if there is low blood volume or low volume, there's going to be low water in the extracellular fluid. We're going to have low blood pressure. Then we know that that is going to kick off our renin, angiotensin, aldosterone system, and that we are going to get an increased reabsorption of sodium, and water is going to follow, and that's going to restore our blood volume and our blood pressure. If we have too much volume in that extracellular space, that extracellular fluid, that's going to increase blood pressure. Then we're going to have a decrease in that renin, angiotensin, aldosterone system, and then sodium will be excreted, and we know that water follows salt. And so that's going to help us maintain the water-sodium balance. Yep, because water always follows sodium. As far as dietary intake, 9 out of 10 Americans consume too much sodium in their diet. And so this is just saying the adult really needs only 180 milligrams. Recommended is going to be 1,500 milligrams. Upper end for that is going to be 2,300 milligrams. And they're saying that the American adult consumption is really more than twice of what is recommended. And this is really due to the fact that, hey, salt tastes good and it's also high in processed food. So diets that are higher in sodium because of this water-salt relationship are associated with an increased risk of developing hypertension. Okay, so we know that aldosterone directly controls sodium reabsorption. And so triggers, just kind of this is all review. We know when we have decreasing blood pressure and or low sodium ion concentration in the filtrate of the kidneys, we're going to get that release of renin from the kidneys. Renin is going to stimulate angiotensinogen to be converted to angiotensin 1. When it goes through the lungs, we have angiotensin converting enzyme. And then we get angiotensin 2, which is a powerful vasoconstrictor. We also get, which is going to help us with our blood pressure, we also get the release of aldosterone from the adrenal cortex. Aldosterone is going to stimulate sodium, and because water follows, reabsorption in the distal convoluted tubules and collecting ducts. And remember what's going to scream, remember our autoregulation that is happening at that magical place called the JGA, the juxtaglomerular apparatus in the nephron. We know when there's low blood volume and low blood pressure, those JG cells, they don't get stretched. So they're going to open up nice and big to allow more blood in the glomerulus. And we know the macula densa is the one that's going to detect that the filtrate is moving too slowly. It's not salty enough. And that's when we get that release of renin. So that's where that magic is happening. And remember, the kidneys have to reach their quota of 125 mils per minute. And so that's why they are so responsive to low blood pressure, because then they can't do their job. The second one, this is the first time we are adding this, so this is new information. If there is an increased amount of potassium, because aldosterone controls sodium and potassium, it causes the reabsorption of sodium and the excretion of potassium. So if there is high potassium that we need to get rid of, that is going to stimulate the adrenal cortex to release aldosterone. Its target is the distal convoluted tubule and the collecting ducts. So we get that sodium reabsorption, which we've talked about, but we also get that potassium secretion. So we're just adding that extra little piece in for you. And so we can get rid of our excess potassium. And so that's going to restore homeostatic plasma levels of both sodium and potassium. So that potassium gets excreted in the urine. We also, just don't forget too, adrenocorticotropic hormone, we will also get the release of some aldosterone that way as well, because we know blood pressure goes up during times of stress. All right, so just make sure you got it. What effect does aldosterone have on sodium levels? Are they going to go up or are they going to go down? All right, what effect does aldosterone have on blood volume? Which compartment are we talking about when we're talking about aldosterone's effect? Intracellular or extracellular? Ooh, yeah, I threw that one in there. Okay, so that's new. So when we talk about blood volume and plasma volume, just keep in mind that is the extracellular fluid compartment. What effect does aldosterone have on blood pressure again? So we talked about aldosterone, but we know that too water has an influence over sodium through ADH. We just kind of covered that. So ADH controls osmolarity through the control of reabsorption of water, and aldosterone controls blood pressure through fluid volume. And so they do have overlap. And so just kind of saying they're working from different ends, but the same result is occurring. When we're talking about antidiuretic hormone, we are absorbing more water directly, so we get more retention of water and then we raise that blood volume, which of course is going to raise blood pressure. When we talk about renin, angiotensin, aldosterone system, we're reabsorbing the sodium. Water just follows, so we also get that same effect of upping volume. And so they both kind of are crossing over and working together. Our one antagonist is atrial natriuretic peptide, so AMP makes you pee. It is that antagonist. And so just kind of reminding you that when we have too much volume, so too much fluid in that extracellular space, high blood volume, high blood pressure, we get stretch of the atria. And so they are going to release atrial natriuretic peptide. And pretty much AMP is going to inhibit everything that aldosterone and ADH does. And so coming over here, it inhibits the release of renin. If we don't have renin, we have less angiotensin 2, get that vasodilation. So we're going to get that relaxation and a drop in blood pressure. It is going to inhibit the hypothalamus. So we're not going to get ADH release. We're not going to get aldosterone release. So we're going to get inhibition of water and sodium being reabsorbed at the kidneys. So that's going to lower our blood volume and lower our blood pressure. So really, we've got all these things to raise it. So ADH, renin, angiotensin, aldosterone system to raise blood volume, blood pressure, and we only have one that drops it. And that is ANP. And just kind of remember, ANP makes you pee. All right, so what effect does ADH have indirectly on sodium levels? And I'm just kind of tying this together. So antidiuretic hormone, if we absorb more water, what happens to sodium? So if we increase the volume and we don't do anything with sodium, we're just adding more water, that actually is going to lower sodium levels. So it's kind of like, think about that, just water, just taking in only water when you drink, you're diluting out your sodium. Okay, hopefully sodium's all clear for you. Calcium, so looking over here. So number one regulator of calcium is going to be parathyroid hormone. And so when blood calcium levels are low, there are receptors for calcium. This is looking at the back of the thyroid gland. There's 4 small masses. Parathyroid hormone has a 3-pronged effect for raising blood calcium levels. It stimulates those osteoclasts to chew up bone and release calcium in the bloodstream. It stimulates reabsorption of calcium from the distal convoluted tubule and collecting ducts. It also activates vitamin D, so we get calcitriol, so we can absorb all the calcium from our diet, and that is going to raise blood calcium levels. To be super honest with you, calcitonin is not something that needs to be replaced. Calcitonin does lower blood calcium levels. It can be given therapeutically. And it does stimulate osteoblasts to take up calcium and put them in bone, but it's not really a big player. It's really just going to be the negative feedback, either the presence or the absence of parathyroid hormone that are controlling calcium. Okay, so we're going to take another break. You're going to do your concept maps 1 and 2. Go ahead and get that done. And I will come back.